recording button. Dr. Shvet, please give some introduction about you and you can start the class.
Yes, sir. So, good evening, everyone. My name is Dr. Shvet. I my DNB Neuro training from Apollo, Delhi. Gave my theory exams. I'm waiting for practical exams. I live in Zirakpur, Punjab.
Yeah, we will wait for 2 more minutes. 5:50 we can start.
Right.
Shiva, time allotment is 1 hour.
Thanks.
Hello, Shiva.
Yes, sir.
1 hour. I think you can take history for half an hour and examination for half an hour.
And 5-10 minutes electrophysiology.
That's okay, sir. Okay.
Right, sir.
Shall we ask them to analyze symptoms when they present itself, sir, or should we ask them to present?
Yeah, we can tell them while presenting only, like exam.
Sorry.
We'll start, sir.
Yes, you can.
Sir, my patient is. Yes, sorry, sir. Sir, so my patient is Mr. Suresh, 74-year-old male. He's a graduate, a businessman, resident of Mauritius. Informant was patient and his wife, and reliability is good. Patient is a right-handed person. He came with chief complaints of weakness of all 4 limbs since last 6 months. History of presenting illness. The patient was apparently normal 6 months back when he noticed that he was unable to grip his slipper from right foot, and his slipper would slip off from his right foot with his awareness. There was no history of foot drop or tumbling while walking, or history of buckling of knees, difficulty in getting up from low-lying stool, or any loss of sensation over any part of limbs. And there was no history of weakness in upper limbs or any backache at that time. Sir, proceed.
Okay,
sir.
you can ask some questions now.
Yes.
Dr. Mohan and Dr. Veda.
Yeah, thank you. Doctor, you can analyze the first symptom.
Right, sir. Sir, unable to grip his slipper with awareness indicates distal lower limb weakness in the right side.
Okay.
And, yes, sir.
What is the significance, doctor, with the Shvet, with the awareness and without awareness?
Sir, in this case, I would probably think that it is with awareness is like this. There's no sensory involvement, and this probably indicates its intrinsic foot muscle weakness.
If it is without awareness, what does it do?
So if it's without awareness, then it's probably involving the proprioception loss.
Okay.
Then, so 1 month into the illness, patient noticed that he had episodes of buckling of his knees, and had reported that he had difficulty in gripping slipper from left foot, and had noticed that he was unable to get up from low-lying stool and would require the support of side walls or his relatives to get up. This was 1 month after the onset. And wife also reports that he used to walk with the waddle after getting up. So, sir, buckling of knees uh, um, indicates so, the extensor weakness, knee extensor weakness, and again gripping slippers from the left foot is distal lower limb weakness, and this low lying stool, getting up from low lying stool indicates the hip, hip, um, hip, hip extensor, hip extensor weakness, and and waddle indicates probably this hip abductor weakness.
So what does it mean, doctor?
So waddle is like walking like a duck, sir.
Is it rapidly progressive?
It is rapidly, like yes, sir, 1 month into the illness, it is progressing rapidly.
Unilateral or bilateral it is?
So initially it was like it started on one side, then it became bilateral. Sir.
Then what does it indicate? What is the disorder you are expect from at this point?
Sir, so
Onset is
onset was asymmetric, sir.
asymmetric, and
Yes,
which is distal in onset.
yes, sir. Distal onset and asymmetric. Yes,
Proximally.
and yes, sir, and progressing proximally, sir.
And involving all group of muscles, you said.
Yes, sir.
Hip abductor, knee extensor.
Yes, sir.
Then what could be the reason? What type of weakness it is?
Sir,
Whether LMN or cortical or spinal cord or muscle or peripheral nerve, what it will be there?
sir, this like it could be like said with such acute like this onset could be neurogenic, sir. This involving the involving anterior horn cell or involving the roots or the nerve.
If it's a root, like what do you think?
Yes,
Is
a
it
root
a single
onset.
root?
So root onset generally is proximal. So
Okay, but here what are the hip extensor, like hip abductor is involved, right? Hip abductor, knee extensor. There's some foot drop also initially. So what do you think of the root involvement or root of hip abductors?
hip abductors is L5
Knee
L5 to
extensor,
S1. Yes, sir. L5 S1 S2. Yes, sir.
knee extensor.
L3 L4 sir, knee extensor, sir.
Actually, more than one segment myotome is getting involved, right? Like more than one root, and then it's spreading to the opposite side. So
Yes, sir.
is root a possibility here? Like seems less likely, right? I don't know. Unless if it is something like an arachnoiditis which is getting involved.
So somebody with a polyradiculopathy will have proximal onset, sir.
Yes.
Okay.
Yes, sir.
Then what type of weakness? Root is not involved. Then
root is yes, sir. Root is not involved, sir. Then it doesn't.
L5 myotome means
Buckling? What about the buckling? Is that that is very specific for one type of weakness, right? Like in LMN and UMN.
Buckling, sir.
Buckling is it an LMN sign or a human?
So buckling is
any stroke patient has buckling. Is any stroke patient has buckling?
stroke.
LMN sign.
Elements.
Buckling.
Okay,
Why it doesn't occur in human?
Buckling as a UMN, sir.
No, why it doesn't occur in human weakness? I'm asking buckling.
Sir, because you
Pattern of weakness.
yes, sir,
The
UMN.
yeah,
Yes,
yeah.
yes,
So
sir.
the knee flexors are more weak than the knee extensors in a human
Yes,
pattern
sir.
of weak.
Yes, sir.
So that's why.
Flexors in lower limb. Yes, sir. So then, root is not involved, and in the nerves, multiple nerves progressing.
So what is the one point which is against nerve here?
So there's no sensory loss.
Very good. One more proximal involvement is also there.
Yes, sir. Proximally, it has progressed.
Very rapidly.
Yes, sir.
Okay.
And muscle, it is progressing. Muscle is also again proximal, so generally distal onset. With rapid progression is unlikely, sir. Though, there is one which can progress, but that has probably a subacute onset in inflammatory. That
Okay.
yes, sir. IBM, sir. Yes.
I think let him continue, sir. Veda, sir.
Sorry, sir.
Dr.
Yes, sir.
Shvet,
Right, sir.
please.
Simultaneously, patient noticed that both lower limbs were getting thin and would have spontaneous muscle twitching all over the both lower limbs. No weakness was noticed in upper limbs, trunk or neck. No sensory impairment was noticed over any part of the limbs. No history of any bladder or bowel incontinence was there. This was again that this is 1 month after the onset. Then this thinnings are associated with weakness goes more in favor of anterior horn cells, and then associated with this twitching fasciculations.
Where else did you get this thinning and twitching? One is your anterior horn cell. Where else you can get?
Twitching can also
Causes for fasciculation.
Fasciculation.
fasciculation, sir.
Yes, causes for fasciculation.
Causes, sir. The first is this benign fasciculations are there, sir. Then patients can have it can be mistaken with the myokymia, sir.
Okay.
And also
radiculopathy also can cause sometimes fasciculations.
radiculopathy, yes.
Root involvement can also sometimes cause fasciculations, and benign fasciculations can occur.
Yes, sir. Then it's also possible in nerve disorders, sir.
Yeah, and neuropathy is also some, but commonly in anterior horn cell. Second, I think would be root involvement. Then less commonly in nerve disorders also.
Neuropathies.
Neuropathy. Okay.
Yes, sir. So then 2 to 3 months into the illness, patient noticed
in
that
neuropathy, if you notice this sort of fasciculation, which type of neuropathy would you suspect? Like so much of wasting.
yes, sir.
Is it like abnormal or demyelinating?
Sir,
More wasting?
yes, sir. It probably be an axonal, sir.
Okay, axonal, because the nerve fibers are all completely lost, so there will be more wasting in axon. Okay.
Yes, so then 2 to 3 months into the illness, patient noticed that he would need the support of side rails of bed to turn himself in the bed or to get out of the bed. Simultaneously, patient also noticed that his lower limbs were getting thinner than before, and he would feel stiffness in the legs, especially in the morning hours. No similar symptoms were reported in the upper limbs till then, or nor any sensory symptoms were reported over any part of the body. So, sir, this turning in bed and getting out of bed, I take that as a truncal weakness. And this stiffness, I'm putting this to sir spasticity in the legs, sir, associated with the atrophy.
But why is it, especially in the morning hours, the stiffness, when you get stiffness or rigidity, like is it present continuously or is it on and off?
So that like they say that there's some this cold paresis is the term, sir, and probably morning it is cold, so maybe.
Could this be cramps?
Sir, can be cramps, sir. Yes, sir. Cramps is also a possibility, sir. After night, sir. But night cramps are generally nocturnal, sir. So, the morning.
No, especially when you're presenting something like anti-onsel, this is like a case of anti-onsel, like so much of wasting and thinning and all. Cramps should be very high on the list, and especially when it is on and off, like it's coming in sleep and all. Like better to consider cramps also rather than just spasticity.
Okay, sir.
Because cramps are quite common in anti-onsel disorder, MND or ALS. So
Right, sir. In 4 to 5 months into the illness, patient also noticed that he had difficulty in gripping the pen while writing. Simultaneously, he also noticed that he had difficulty in opening the jars. He had difficulty in gripping the mug and lifting his arm above the shoulder level while pouring water during bathing. At the same time, the patient also noticed that his upper limbs were also getting thinner and had spontaneous muscle twitching over both shoulders, chest, and arms, with stiffness in upper limbs. Uh, there was no history of any diurnal variation in the weakness of the limbs. Sir, so this was gripping. I take this as a distal limb weakness, and it also involved proximal upper limb weakness associated with the atrophy and fasciculations. And again, the stiffness, probably cramps or spasticity. May I proceed, sir? Yes, sir. So then there was no history of any form of any neck weakness. Patient can lift his neck well above the plane of the bed. There was no history of any difficulty in swallowing or breathing. There was no history of any form of sensory impairment over any part of the body. There was no history of any form of imbalance, and no history of any incontinence of urine or stool or erectile dysfunction or postural syncope. There was no history of any headache, loss of consciousness, seizure, or involuntary movements. No history of alteration in behavior, loss of planning, inappropriate laughter or crying in any form or any form of memory deficit or any other form of cognitive deficit. There was no history of any vision abnormality, double vision, facial asymmetry, dysphagia, dysarthria, neck weakness. No history of trauma, fever, other constitutional symptoms, weight loss, chronic cough. No history of any backache, neck pain, spinal deformity, tenderness. No history of any high risk behavior. No history of loose stools or toxin exposure. No history of ulcers, joint pain, or rash. Currently, the patient is dependent on his relatives for carrying out his daily activities of daily living. He can lift his limbs above the plane of the bed.
onset is 6 months into the illness, right? Now?
Yes, sir. 6 months. He can lift his limbs above the plane of the bed and walks with support of walker or with the help of his relatives. Patient is continent of bowel and bladder and has no sensory impairment or bed sores. There's no significant past history and there's no significant family history. Patient is on a mixed diet, sleep is adequate, bowel bladder is normal, continent. There's no history of any smoking, alcohol intake, or toxin exposure.
Vedas, sir?
What can you able to say that why you are asking no step so much? Can you explain why there is you are asking that? Why we are asking that no step neck weakness, no step swallowing difficulty, no step sensory impairment? Can you able to explain what
Sir,
question you are trying to rule out?
yes, sir. Sir, neck weakness is again like if in this uh, it hasn't involved the neck or the sir bulbar or respiratory involvement till now, sir.
Good, good.
Yes, sir. Sir,
Bulbar muscle.
yes, sir. Then there is no, sir, imbalance was because of this cerebellar, sir, involvement, sir. Then there
Okay,
is
fine.
in urine this autonomic features because of any cord involvement, sir.
Okay.
Yes, sir. Then there's no this altered behavior, this inappropriate laughter. This is basically, sir, this uh, FTD and this pseudobulbar effect, sir.
Okay.
Yes, sir. Then this vision abnormality double. This is dysphagia, all because of lower cranial nerve involvement, sir.
Oh, what cranial nerve you expect for this patient? Which cranial nerve will be involved in MND?
Sir, in MND, tongue, sir, we'll look for tongue fasciculation, sir.
Okay. Other cranial nerves?
Other, sir, patients have said this seventh can involve, sir. Then optic in other secondary causes, or hereditary causes, this optic atrophy and so retinal pigmentation can be there, sir.
What is that syndrome?
Sir,
Optic nerve deafness, MND.
sir, um, no,
Believe it, I don't know.
is it
Actually, there is some syndrome is involved there, but you only caught that.
brown one, violet one recent of, sir.
yes, sir, maybe at least.
That is like some transporter deficiency of riboflavin. So usually in children.
Yes,
So
he mentioned that.
bulbar with hearing loss, sir, predominantly.
What is Madras motor neuron disease?
Sir, Madras motor is seen in generally.
Which cranial nerve is involved here? Seventh or eighth? Or both?
Sir, I think seventh, no, sir.
Both, I think.
Both, sir.
Seventh and eighth is involved. MND, Madras motor variant. So you must know why you are ruling out other systems. So little bit you have to know about other variants of MND. Then only you can able to say.
Yes,
So
sir.
here, in this case, what is the variant? Which type of MND? Where did it start?
So this is like the classical, sir, limb onset, distal limb onset, sir.
This is like the pseudoneurotic, like foot drop like variant. That's what the badly gives, pseudoneurotic like variant. So usually, classic MND is an upper limb, right? Isometric upper limb. So when it says foot drop, they usually call it as a pseudoneurotic variant.
Yes, sir.
So then this back, yes, sir.
Okay, yeah, please.
Sir, this neck pain and spinal deformity tenderness was to rule out a cord etiology, sir. Then high risk exposure is again HIV, HTLV, and this toxin exposure is heavy metal and other pesticides. This I just wrote because of Sjogren syndrome, sir, ulcers, joint pain.
Any toxins that cause this fasciculation or
Spasticity.
Toxins are
Fasciculation, toxicity.
normally, sir, in OP we get OP poisoning. Yes, sir, but like OP, I don't think, sir, it is like etiology for this ALS. Sir.
Not here, not here. I'm just asking fasciculation and toxins. So not here. So what else can you think like localization here other than the antirhonsel? Okay, one is antirhonsel. What are the
Yes, sir.
points for and against antirhonsel here?
Sir, points for our distal onset and asymmetric distal onset, and rapidly involving the proximal uh, lower limbs, and then actually sir, written the summary, sir.
Yes.
Um,
You can read
yes,
the
sir.
summary.
Yes, a 74-year-old male with no known comorbidity presented with 6-month history of insidious onset, gradually progressive, pure motor weakness, asymmetric in onset and distal, followed by proximal beginning from right foot involving left foot over next 1 month, followed by weakness of trunk and upper limbs in next 3 to 5 months, with history of stiffness in limbs, with significant thinning of limbs and multi-segmental fasciculations all over the body without any sensory impairment, bladder, bowel, incontinence, cognitive impairment, cranial nerve involvement, neck pain or backache, constitutional symptoms, high risk behavior or spinal deformity or trauma.
So first localization, anatomic localizations.
Sir, first is sir, anterior onset, sir, then next.
Any other?
Sir,
Is there any points against antirhonsel here? Shvet?
Sir, it's a bit too rapid, sir, to progress in 6 months, sir.
Slightly rapid, but then other things, everything is favoring antirhonsel. Pitching, fasciculation, I mean thinning, everything is favoring antirhonsel. Anything else? Anatomic localization.
Sir, like this a muscle disease, sir, if we consider this uh, inclusion body myositis, sir.
Okay, but what are the points for and against?
Sir, there is no other like the points for, sir, like the points for, sir, this rather it is against, sir, that it is a more that quadriceps and finger flexor weakness in that and also asymmetric, yes, sir, and bulbar involvement with difficulty in swallowing in I-beam, sir.
So actually, there's so much of pitching, fasciculations, thinning, everything is against muscle disease, and the distal involvement starting. I don't know, like IBM usually is asymmetrical, but starts with buckling and thigh muscle involvement.
Proximal nerve.
And, distal upper limb. So I don't know, distal lower limb both getting involved so rapidly is definitely, I think, against IBM. But more common, like more importantly, I think MMNCB is definitely possible. But what are the points against MMNCB here?
Sir, points against, sir, that again this thinning and fasciculation, sir, against, sir. And,
Yeah, thinning. Okay, thinning can occur. Fasciculations. Okay, that also they say sometimes it can occur, but usually it's upper limb onset, asymmetrical, slowly progressive.
okay, sir,
So these
it's
are some general features in MMNCB. Usually upper limb onset, asymmetrical, root, individual nerve distribution, and middle-aged people. So that is how usual characters are. So these are some points which are against MMNCB. But definitely a pure motor weakness with thinning, definitely better to consider that also as a DT.
yes, sir. So
And
that
the
is
proximal involvement is also here. It is in upper lower limb it is present. So it is now something also to consider against MMNCB. Yeah.
And spasticity.
So how common spasticity? Yeah. So I don't know how much to rely on that as a sign in history, sir. But then definitely spasticity is there by history. I think that's a point against MMNCB. How common is cranial nerve involvement in MMNCB?
Sir, I think it occurs in 15 to 20% of patients. Sir.
It's not that common. So bulbar involvement is not that common at all in MMNCB.
Okay, sir.
Any other localization? Anatomic localization.
Sir, the sides are muscle nerve and anterior cell, and then NM junction is ruled out, sir, because there's no fluctuation, sir.
Okay.
And cord and this brain stem is again also not involved, sir.
Okay. So pure motor nerve is one thing we told. Pure motor is MMNCB. Then pure motor CADP is possible.
Pure motor CIDP,
What is the point against pure motor CADP?
again sensory symptoms are absent, sir.
No, pure motor. Okay.
Pure motor.
Okay, sir. Yes, sir.
Symmetrical, right? Symmetrical, more proximal and distal equally getting involved. So, okay.
And if fasciculations can be there, sir.
Wasting are not prompt. Yeah, rightly said by someone.
Then, sir, other differential of ALS can be, sir, like some probably Lyme's disease. Is that a possibility we can keep?
Okay. That again is the root, right? Polyradical.
Good
That is
enough.
the lesion like.
Yes, sir.
Again, the growth is symmetrical involvement.
Usually, the Lyme's is the plexopathy. Polyradical.
Okay.
Yes.
We'll proceed, sir.
Yes, you can.
Yes, sir. Then, sir, can we keep syrinx in this? Syrinx?
What is the point against syrinx here? What is the point for syrinx here?
Sir, syrinx like usually has this suspended like sensory loss.
Usually.
Sorry, sir. Sorry.
The first symptom usually in a syrinx.
Like the hands are burnt, sir. Pain and temperature loss, sir.
Okay.
The
So,
fingertips, yes, sir.
so crossing sensory fibers getting involved. And yeah, the location of the involvement depends on the location of the syrinx. If it's a high cervix or cervical cord involvement, like C81 syrinx, then the hands get involved. If it is a high syrinx C2, C3 or there, you can get even a Charcot's joint of your shoulder. So depends on but the first symptom is usually a sensory loss, right? Here there is no sensory involvement. That is one point against syrinx. And there is element signs like involved diffusely, right? Like upper limb, lower limb. So the syrinx should be like very extensive one, right? For so much of element signs. So
Okay, sir.
and okay, and bladder usually comes a bit. Bladder involvement can occur, right?
Yes, sir. Bladder can be involved, sir. Yes.
What about compressive myelopathy versus your case?
Yes, sir. Cervical compression, some spondylotic myelopathy. That is, yes, sir. That can occur, sir.
What is the point against compressive myelopathy here? Cervical compressive myelopathy.
Sir, sir, probably also it should have some sensory ataxia, sir. Proprioceptive, the posture.
One is sensory symptoms. Other is the most important is you have element signs in your lower limb, right? So the element never occurs in lower limb in a cervical compression, right? It's always human in the lower limb and element in the upper limb. Even if it's a upper limb element, it's only the segmental element involvement. Whichever segment is getting compressed, there only you get element. So that is a very important point which is against cervical compressive myelopathy here.
What about fasciculation in myelopathy, compressive myelopathy?
Fasciculations in myelopathy, sir.
There will be option.
Yes, sir.
There will be option. What is spinal myoclonus?
Spinal, sir, it is like sudden jerky-like movements of the involving the trunk and the limbs in a spinal myoclonus, triggered by a sound or
Segmental. It is segmental involvement of root at the level of spinal cord. Segmental root involvement at spinal cord. That will lead to spinal myoclonus. Is it fasciculation or spinal myoclonus in your case?
in our case, sir, it is like multi-segmental, sir. So it's like
Whether it is compressive myelopathy.
compressive myelopathy, sir. Involving diffusely,
Yeah.
sir, is it?
You already said it is segmental. So it involves only segment of that compression. So you cannot expect huge compression from top to bottom to produce so much fasciculation all over the body. So unlikely to be compressive myelopathy. What are the other points favor for compressive myelopathy? Sorry, against compressive myelopathy.
Against, sir,
You have said fasciculation.
it was asymmetric, yes, sir, asymmetric in onset that it was favoring, sir. Points against, like sir said, that sensory is against. Yes, sir.
Okay. Okay.
Bladder symptoms against bladder is present.
Yes, sir. Extra will be blood will be late. Yes, sir.
I think I told something a bit wrong. Usually in syrinx, is the bladder involved late or early?
Syrinx, sir, is intra-central, so it will be early, sir. Early involvement.
No, I think you just check up on it. Most of the intramedullary are early, except syrinx. Syrinx is a exception for bladder involvement. Please check up on that.
Yes, sir. I think so. That is correct, sir.
Syrinx is usually an exception, and then exception for other intramedullary lesions where syrinx only the bladder gets involved late.
Yeah, what is the pathophysiology behind why syrinx will have late bladder?
I think, sir, it's probably because it's a cavity, it doesn't cause that mass compression seen with lesions, sir.
Yeah. Yeah, bladder fibers are pushed, but not there is not sudden pressure. It is a chronic disease. So it will cause late bladder presence. Okay.
Check, sir.
Okay, sir. You can proceed, sir.
Proceed, sir.
Proceed, yeah.
Like, CIDP was there in your possibility?
Yes, sir. Motor CIDP, we said, sir. Pure motor CIDP.
Yeah. Okay. What else can be the other possibilities?
Sir,
In this age group, any other possibility you have kept?
sir, etiology wise, no, or the localizations.
Yeah, etiology wise.
Etiology, sir, like one is paraneoplastic, sir.
Yeah. Okay, what is neuronopathy and what is axonopathy?
Sir,
What is ganglionopathy?
Yes, sir. In sensory neuronopathy, sir, we have this dorsal root ganglia involved, sir. It presents with the sensory ataxia and uh, so,
What are the features of ganglionopathy?
sir, non-length dependent weakness, sir.
Okay. And what else?
Sir, autonomic features, sir.
Yeah, autonomic features will be there. Ataxia, reflexia, some
Reflexia.
fasciculation.
Fasciculations, okay, sir.
What is difference between small fiber and large fiber neuropathy?
Small, sir, usually has so pain temperature, and large fibers have ataxia, sensory ataxia.
Okay.
Yes, sir. Small
So what
fibers.
will be the complaint? Small fiber neuropathy patient, predominant complaint.
Predominant complaint is, sir, so, sir, yes,
Small fiber neuropathy.
dysesthesia, sir, dysesthesias.
Yeah, pain, burning pain.
Yes.
Painful neuropathies, right? All these small fiber neuropathy.
And large fiber, what will be the presentation?
Large fiber is, sir, sensory ataxia, sir. Then areflexia. And,
No, it's like that. Usually a sign, right? So symptom is usually ataxia.
Ataxia.
yes.
Okay, go ahead.
It's general physical examination. Patient was alert, conscious, cooperative, moderately built and poorly nourished. His BMI was 17.6 kilogram per meter square. Pulse rate was 86 per minute, regular, normal volume and character. Blood pressure was 130 by 80 millimeter mercury in right
You
arm.
should have given bird syntax also, because one of the DD was syrinx or some CV junction anomaly.
Neck height ratio, sir.
Neck height ratio.
Right, sir. I haven't kept that, sir. Next time, keep it, sir.
Okay, go ahead.
130 by 76 millimeter mercury in right arm standing with support, and patient was afebrile. Respiratory rate was 18 per minute. Single breath count was 42. There's no pyrrectus, clubbing cyanosis, lymphadenopathy, edema, or bed sores. There was no neurocutaneous markers, thickened nerves, or hypopigmented patches. Then nervous system examination. MMSE was 29 by 30. Patient couldn't draw this pentagon because of difficulty in gripping the pen. Then bilateral palmomental reflex was seen. No other frontal release signs were there. Then cranial nerve examination. First olfactory normal. Then second cranial nerve visual acuity was 6/6. Color vision was normal. Confrontation normal fields, and bilateral light reflex, both direct and indirect, were present. There was no optic atrophy on fundus. Then extraocular movements were normal. There was no nystagmus or and saccades and pursuits were normal. Then fifth, corneal reflex was bilaterally present, and there was no sensory impairment over face. Muscles of mastication, there was normal. No deviation of jaw opening the mouth. Jaw jerk was present.
What is the
While
eye sign? This is something they ask, right? What is eye sign in MND?
eye sign, sir,
Some reflexes there.
reflex.
Okay, so corneomandibular reflex they say. So that's an eye sign which is present in MND. Usually other extraocular movements and other eye signs are all normal. This is one. I think it's a reflex actually. Fifth and even in Dijong only. So you can just put fifth now cranial nerve chapter.
Yes, sir. Corneomandibular reflex. Okay, sir.
How do you elicit that corneomandibular reflex?
Sir, probably stimulating the touching the cornea, sir, from the side, and there maybe some this masticatory movements.
Okay. What is meant? What will do while touching the cornea? What will be there?
So
Mentalis. No, the mentalis.
Okay, mentalis will contract, sir.
Yes.
Then bilateral facial expressions were normal. Forehead furrows and nasolabial folds were normal. There was no deviation of angle of.
MND, like all the motor cranial nerves can be affected, except your 3, 4, 6. Like fifth can be affected, seventh can be affected, 10th cranial nerve, 12th cranial nerve, all can be affected, except your 3, 4, 6.
Okay, sir. So then bilateral, no deviation of angle of mouth on attempted smile, and bilateral orbicularis, oris and oculi for normal. Eighth cranial nerve, Rinne's AC was greater than BC, and Weber test was equal on both sides. Then gag reflex was normal, uvula was central. Then trapezius and sternomastoid, sternocleidomastoid.
What is neck drop, neck drop, neck drop?
Yes, sir. Head drop. This head drop.
Neck drop.
It is of yes, sir. Because of this neck extensor weakness, sir.
So possible causes?
Possible causes is one is this this MND, sir, in the ALS. Then this this
What muscle disorder will cause?
yes, sir, in the polymyositis, sir, and I think
Inflammatory.
IBM, sir, yes, sir.
Okay.
And also this I think there is some congenital neck extensor syndrome also, sir.
Okay, isolated neck extensor muscle weakness. Okay. Any other? Myasthenia?
Myasthenia.
So this is no biases actually. You can just go through drop neck syndrome, drop head. So,
dropped head syndrome, yes, sir.
yeah.
FSHD.
And also, you know, DBS will be given. Neck weakness can be caused. CADP. So neck weakness. So you can just go through the on table is there in Brazil.
Yes, sir. In the tongue was in midline. There was no atrophy of fasciculations. Tongue movements were normal. The motor cyst examination bulk generalized atrophy was seen in all 4 limbs, and multi-segmental fasciculation was seen. Polymini myoclonus was there.
Where like, tongue examination. I don't know whether in this case anti-onset usually they can ask a lot about tongue. Like
Yes,
how what is the question you will actually examine for fasciculation?
we will keep the tongue inside, sir, and look for fasciculation, sir.
So if there is unilateral tongue weakness, they'll ask all these things. If there's unilateral tongue weakness, like on protrusion, like it deviates towards the
Deviates towards the, sir, normal side, sir.
no weak side, right? On protrusion.
We deviates to the weak side. Okay, sir.
Okay.
No.
And
That is
on
human and element tongue lesions are there. So what will be the direction in human tongue lesion and element tongue lesion?
Sir, in elements, sir, it will probably turn towards the normal, and in UMN towards the affected side, sir.
no,
Element, I think.
element it usually goes towards the weak side.
Same side.
Protruding on towards the side of the weaker side. Just go through. So there are 2 things. One is how the tongue deviates on protruding, how the tongue is on keeping inside the mouth. So usually in an element lesion, the tongue usually deviates towards the side of the weaker muscle when you protrude it out, and it goes towards the side of the normal side when you keep it inside the mouth.
Okay, sir. This is an element, sir. And,
Yeah, this is an element. This is in De Jong only is there.
and in human also, sir, same. Is it the same?
Human, yeah, human. The thing is, see, when your left hemisphere is involved, your right side tongue is weak, or when you're so. I mean, I don't know about a human tongue because bilateral innervation is there. I'm not very sure about human, but the element is this thing. This is given in De Jong. I'm not sure about human. Please go through human. I'm not sure.
Right,
But
sir.
element is this. When there is a right half of the tongue is weak, usually it goes towards the right side on protrusion.
Yes, sir. And on keeping
And
inside, it is on the.
that is the rule of 17, right? 10 and 7 go towards the opposite side of the weakness. Am I right or wrong? I don't know.
You're
12
right,
and
sir.
5
You're
go.
right. 10
Okay.
and 7 is correct. 17.
Yeah.
But anyway, you go through
Go,
Shvet, you go through that
go
human
through
and
Shvet.
element analysis. Yes.
They'll definitely ask
Got
you.
confused now. Yes.
Right, sir. Then motor system examination, bulk generalized atrophy of all four limbs, multi-segmental fasciculations was seen, and polymany myoclonus was present. Then right upper limb, the arm diameter is 22 centimeters, and forearm was 15 centimeters, and the right thigh was 30 centimeters, and the calf was 24 centimeters. And on the left side, the arm was 21, and the forearm was 15, and the left thigh was 30 centimeters, and calf was 24.5. There was no significant difference. Bilateral FDI was atrophied. Then
Only 5.
So what is the split hand?
so split hand, sir, is more involvement of the this thenar as compared to the hypothenar muscle, sir.
Okay.
Usually seen in this MND, sir.
Okay.
And, I think the opposite is true in, sir, this Hirayama, sir.
Why? Okay. You're saying the thenar is paired and hypothenar is involved.
Yes, sir. It's like more involved, sir. Both like as compared to thenar and hypothenar. Yes.
Okay, I don't know. This is new. I don't know. Usually, what is paired in Hirayama? Which muscle is paired?
Brachioradialis, sir.
Brachioradialis. Okay. Oblique atrophy. It's called oblique atrophy, right? So
Okay, sir.
why is it paired?
Sir, usually the involvement is from C7 to T1, sir.
That is higher
Yes, sir.
leg muscle.
Yes, sir. C5, C6. Yes, sir.
Okay, so that is okay.
Yes, sir. So the tone spasticity of grade 3 was seen in all four limbs. Power, shoulder 3/5, and elbow again 3/5. Wrist 3/5.
Here, I think it's better to give a muscle. I don't know, muscle based power. I don't know, sir. What do you think, sir? I don't know. Like we used to do individual muscle examination because the myotomal. Some people may be specific. I'm not sure. Individual muscle examination may be a better option here if it is kept as a short case. Like,
Definitely, sir. He has a fasciculations,
yes, sir.
atrophy, everything is there. He must, it will require. So instead of putting a
Obviously,
shoulder
when-
girdle, elbow girdle, individual muscles, it's better.
Okay, sir. Then elbow 3/5 and wrist 3/5, and then hand grip was 50%. Neck was 4/5. Trunk in 2/5, and thigh weakness. This hip was 3/5, and then knee 3/5, and ankle 3/5. Superficial abdominal reflex was absent. Hemastric was absent. And
What happens to abdominal reflection? ALS?
yes, sir, it's absent, sir.
Usually it's preserved, right? ALS, abdominal reflection. What is?
In ALS, sir.
I'm just
Usually
asking
preserved.
about ALS actually. So usually superficial reflex are lost in
Women, sir.
human. Okay. But one exception is your ALS, right?
ALS.
ALS is an exception usually, except in later, late in the disease where it is lost. Okay.
It's and trimestral was absent, and bilateral plantar was extensor. Deep tendon jerk supinator and was present 1 plus in both sides, biceps 2 plus both sides, and triceps again 2
But
plus.
it is always better to say the finger flexor or knee, wrist flexor also here, because you have intrinsic muscle probably wasting and all may be present. So better to say finger flexor, wrist flexor, and even Hoffman, Wartenberg, all these things. Yeah, so it's better to say all these things.
It's, the knee
So all these things will just tell you that the wasted segment of muscle is having some reflection. It'll just reinforce the diagnosis of your ALS.
uh, so then sensory system, pain, temperature, vibration, joint position, and touch was normal, and cortical sensations were normal. Cerebellum couldn't be tested because of power 3/5, and gait, patient had bilateral foot drop when he was made to walk with support. Then spine, there was no deformity or tenderness, and neck movement there was no restriction or tenderness or meningeal signs. So diagnosis, functionally it was a quadriparesis with the LMN and UMN signs, and the localization was corticospinal tracts and multi-segmental anterior horn cells. And, my etiology was MND, ALS, and plan was to rule out other treatable causes. It included paraneoplastic hyperparathyroidism, HIV, and cord compression. Yes, sir.
అట్లా ఉపయోగించు బుర్ర ఉపయోగించబోతుంది
Shvet,
మరి కొచ్చిద్దా మా అమ్మ కొచ్చిద్దా పడినాగా పడినాగా ముక్కలు పోయినాయిలే 2 ముక్కలు ఏంటన్నా పదిహేడు
hello.
Yes, sir.
Shvet, they will ask about plantar reflex.
Yes.
How do you elicit that?
Sir, we
What is the position of the patient while eliciting plantar?
plantar, sir, the patient should be
You
lying
know
so
everything,
yes,
but they
yes,
will ask questions. Yes.
yes, sir. Lying
Which
supine and
article, which article you use to elicit plantar?
sir, we can use this key, sir. Key, okay.
Okay. Or your thumb. You can use your thumb.
With thumb, sir.
Yes. They will ask. What is the plantar response?
So normal is a flexion of the toes and of the great toe, sir. Flexion of the toes. Yes.
Okay, you read it well because they will ask about plantar reflex. Which is important here because you are presenting ALS case. They will ask definitely about plantar response, and they will ask about variants of plantar response. What are the other methods to elicit? If the patient has loss of limbs in the upper or lower limb, how do you elicit plantar? They will ask. I think you can read from Gundu.
I think it is clearly depicted in Gundu or in Alagappan textbook. Plantar response, other responses. And what are the signs you elicited in this case for supporting your ALS?
Sir, this patient, sir, apart from the generalized atrophy, physical lesions, and
Yes.
yes, sir.
What is the tally mini myoclonus?
Sir, polymini myoclonus is
Whether it is myoclonus or it is a tremor.
it's a pseudo name, sir. It is a tremor, sir. It's like multifocal.
I think you only invited the trouble. So you have to very clear whether it is you. If you know that, you can mention that. Otherwise, you will be in trouble. They will ask questions, lot of questions with that. So it is a tremor actually. But how do you differentiate between the tremor and polymini myoclonus? They will ask. So we are only inviting the troubles, so that you can avoid here. Or otherwise, if you are damn sure that you are going to demonstrate and you are going to explain it properly, then you can add it. What are the other signs you elicited here? Atrophy, weakness, then?
That reflexes were preserved, sir. And
Okay, fine. Yes, good.
Spasticity is
Other
one.
sorry, sir.
Spasticity is there, right?
Spasticity.
Yes, sir.
Definitely
And no
here you
other
have to
sign.
elicit Hoffman and Wattenberg. So that is very important here.
Yes, sir. Wattenberg and Hoffman. And this finger flex.
What is withdrawal reflex? Yeah, someone is asking about jaw jerk. What happened to jaw jerk? Why is jaw jerk important?
Jaw jerk was preserved in our case, sir. Jaw jerk can be brisk in patients with the ALS, sir, because of the pseudobulbar involvement.
Okay, so that indicates proximal. Not only the limb, or it also goes proximally, right? Bulbar and all. So that is where it goes
Yes.
higher.
Yes. Then so like withdrawal reflexes are usually elicited when improper technique or pain, too much pain.
What are the components of withdrawal response? Sir was asking about plantar. What are the components of withdrawal?
Withdrawal, sir, machine will have, sir, flexion of the hip and the knee, and there'll be
Flexion of hip, knee, ankle dorsiflexion, and one more is
ankle
extension of
dorsiflexion. Extension of, sir, sorry, sir.
contralateral leg. The other leg will go in
Okay,
for,
sir.
that is another component. This is given in De Jong only. So okay.
Yes, sir. Without.
So why do you get plantar? Why is plantar extensor in a corticospinal tract lesion? What is the normal response?
Normal is flexor, sir. The plantar extensor is that we call that Babinski, sir. Seen in UMN lesions, sir.
That is
It is
actually just go through. So they say as prime. So there is sort of developmental neurology. They would have given some 2-3 points. So just go through why the plantar is extensor in corticospinal tract lesion and all. So there is one nice chapter in De Jong. So just go through that. They'll definitely ask on point.
okay, sir.
And here, yeah, definitely it's a rapidly progressive paraneoplastic has to be considered here. I think 6 months duration, so much of involvement is there. Definitely, you have to consider paraneoplasty. You have to rule out all the malignancies here.
Okay, discuss about lateral foot drop for 2 minutes.
Foot drop, sir.
Drop.
How we are going to proceed this case? What investigation you are going to do?
He mentioned bilateral foot drop. Just 2 minutes of differential lag.
Yeah. Yes, sir. On foot drop, sir. Discussion on foot drop.
Yeah,
Yes, sir.
Yeah.
Sir, foot
So how
drop.
do you approach bilateral foot drop?
Sir, foot drop, sir.
Foot drop. Approach. Sir, is
Yes,
asking.
sir. Sir, the foot drop can be because of peroneal weakness or this L5S1 root involvement, sir, or like in our case, sir, the anterior horn cell involvement.
Any other localization?
Peroneal and sir, then sciatic can be also, sir.
So what about brain lesion and anywhere cortical foot drop?
Yes, a cortical localized lesion can cause foot drops.
Which area?
Sir, this medial frontal area, sir.
Parasite. Okay.
Parasite, yes.
Go from down up. It is like your peroneus muscles. Peroneus and anterior tibial. Tibial is anterior muscle. Or it could be your nerve. Your peroneal nerve. Or it
Yes,
could be
sir.
higher up. It could be peroneal component is sciatic nerve. Go up. It could be your plexus involvement involving particular nerves, or it could be your L5S1 is getting involved. So, or further up, it is cut.
Shiva, they will ask about how do you differentiate between L5S1 foot drop and peroneal nerve foot drop. Understand?
Yes,
Shiva?
sir.
They
Yes,
will
sir.
ask about how do you differentiate between cortical foot drop and nerve foot drop. That is common peroneal nerve involvement foot drop. They will ask how do you differentiate like that. How do you differentiate between L5S1 foot drop and common peroneal nerve foot drop? They will ask like that.
Yes, sir. So, in common peroneal, sir, this everter will also be involved, sir. Everter weakness.
Yes, sir. Yes, you are right. Sorry, has told now. In L5S1, there will be a root involvement corresponding to that myotoma also will be involved in L5S1 foot drop.
Proximal, sir, is telling. Proximal involvement will also be there. Hip.
So you
hip
have
up.
to check individual muscles at the time. So in foot drop, you have to check proximally. Is there any associated abductor weakness is there? Then it could be a higher up lesion, that is L5S1 lesion rather than common peroneal lesion. Like that. You have to go up.
Yes, sir.
Go.
And this tibialis posterior will be involved, sir, in this L5.
So what is the reason for bilateral foot drop in your case?
Sir, bilateral involvement of the anterior horn cell.
Go ahead to investigations. How do you?
Yes, sir. Sir, to rule out the treatable causes, we will do the normal this CBC and the electrolytes, calcium and phosphorus. And
Now, first confirmation of anterior.
Yes, sir.
In electrophysiology.
Yes, sir. We'll do nerve conduction to rule out MMCB and then EMG for this for EMG for this.
Nerve conduction, will you see any changes? ALS. What are the changes in nerve conduction in ALS?
Decreased amplitude in atrophied muscles, sir.
Okay, then
the sensory will be normal.
Okay, then what happened to F waves?
F repeater F and impersistent F, sir.
Sometimes we get giant F also.
Giant F.
Okay. MMNCB, what is there specifically any technique you use to for MMNCB? Shvet?
Yes, sir. This proximal stimulation, sir.
Stimulation also sometimes you can use inching technique also. So just to find out if there is any drop in amplitude or conduction block. So we usually do inching technique also, where sensory inching will be normal, but motor inching will show conduction block. That is characteristic of MMC.
Yes, sir. And then, sir, EMG to rule out myotonias, and it will demonstrate, sir, active this positive sharp phase fibrillations, signs of denervation, sir.
So fasciculation is
Circulations generally, sir, irregular.
how is it seen in EMG fasciculation? What is
Sir,
the
sir, large.
it's a CMAP morphology only. It's very similar to your CMAP or sorry, not CMAP, MOAP. That's what you say in EMG, right? MOAP, motor
Yes,
unit
sir.
action. MOAP, it is very similar to MOAP potential. Okay. Is it regular or irregular?
Sir, irregular, sir, irregular.
Irregular. Okay. What is about fibrillation? Is it regular or irregular?
Fibrillation, sir. Fibrillations are, sir, regular, sir, regular, sir.
Whereas fasciculations are irregular. Okay.
Yes, sir.
What about positive sharp wave? What do they indicate?
Positive sharp wave and fibrillation, fibrillation potential both indicate, sir, active denervation, sir.
Same significance, so denervation. Okay. Okay.
Yes, and
Where does it originate? Fasciculation. Where is the origin?
sir, origin is distal axon, sir.
Okay.
So same question in the reverse order. What are the differential features of myopathy and neuropathy? Denervation and reinnervation in the retrophysiology.
So in myopathy, sir, the comparable recruitment will be less in this neurogenic, and recruitment all will be early in myopathy, sir. And in our case, sir, we'll have this multi-segmental involvement, sir.
Okay. What are the features of denervation and reinnervation?
Sir, denervation is this positive sharp phase and fibrillation potentials, and reinnervation is large amplitude MUAP, sir, with polyphagia, sir.
So what happens to in a myopathic pattern?
Sir, myopathic is early recruitment and polyphasia and so large amplitude MUAPs.
Small amplitude.
It's small amplitude.
So small amplitude.
That is in early, sir, but in late, sir, it will become in chronic. It will again become there.
That is because of necrosis. Okay.
Yes,
okay. Typically, myopathy, the MOAP is small and polyphasic, and complete or incomplete the recruitment.
Recruitment will be complete, sir, in myopathy, sir. Initially, sir, yes, sir. And,
what are the muscles you have selected in your case for electrophysiology?
muscles are this ALS protocol, sir, we have we took biceps, deltoid, and this FDI, vastus lateralis, tibialis anterior. Yes, I think. And also tongue, this we didn't do it tongue surgery. So
What is the type of needle you are using?
we use this reusable needle, sir. This
What are the types of needles?
sir, that flat, I think it was flat bottomed and monopolar.
They will ask these type of small questions. What is the difference between monopolar and bipolar? How do you differentiate? Okay, go ahead.
Then, sir, like after doing this NCVMG, we have to rule out myelopathy. So we'll do the MRI of the cervical spine. And to rule out paraneoplastic, we can do paraneoplastic markers we can send and do the PET scans.
Which paraneoplastic you are specifically suspecting in this?
Sir, lymphoma, sir. Then this lung and lung.
Specifically, which antibodies you want to test? Anything? Okay, go ahead. Next, we have 5 more minutes, 5-10 minutes.
Anti-Hu, sir, we can test anti-Hu and anti-Yo.
Okay, next. How do you manage treatment? Last 2 minutes.
Yes, sir. Sir, in the it's primarily supportive treatment, sir. If all other workup is negative, there are no treatable causes found, sir.
Specific treatment, general treatment. Discuss about the specific treatment.
So specific treatment is like if bulbar symptoms develop, then we need to protect the airway, and we advise the patient PEG, and we can advise this BiPAP support if there is respiratory weakness.
Drugs,
Sorry, sir.
medications,
The medications like riluzole has been tried, sir, but I think there's no evidence now for riluzole, and also this.
discuss about the mechanism of riluzole and edaravone.
Yes, sir. Edaveron, sir. Yes, sir. Riluzole probably acts as an oxygen, and free radical scavenger, sir. Antioxidant and free radical scavenger. I think that's the same for edaveron also, sir.
Better you know mechanism of action, drug, dose, how do you administer the edaravone and riluzole, all these things.
Nice.
Okay, Sailesh sir and moderators, closing remarks, conclusion remarks.
I think it was a good presentation, Dr. Shvet. Actually, just go through more clinical things like I think definitely go through De Jong, but otherwise presentation was very nice. Just go through some clinical points related to that. because not only on the MND they'll ask, but I think they'll go, if you're answering well, they'll go into other areas also. But it was a nice presentation. Thank you.
Yes, sir.
Thank you.
Dr. Veda? I think he will leave at 7 exactly. Dr. Sailesh?
Other important things are this ENMG, some updation, Awaji Shima guidelines, and other thing they can ask, and MND variants, and pattern of weakness, other differential, symmetrical, asymmetrical, sensory involvement is there or not, autonomic, motor, pure motor.
Have we discussed this ALS criteria? Some LS something is there, man?
Yes. LS Coril and Chima, that guideline they can ask.
Awaji criteria.
Okay. Awaji Chima, LS Coril. Okay, Doctor. Nice presentation, Dr. Shvet. And
Thank you, sir.
thank you, Dr. Mohan and Dr. Veda for nice interactive session.
Thank
And Dr. Ramkrishna. Thank you, everybody, every participant. Thank you very much.
Thank you, sir.
Thank you, everyone.
Yeah. Thank you.